In this video, we will be discussing soft tissue techniques around the knee, which includes the quadriceps, hamstrings, and IT band, as well as the calf, which was discussed in a previous video. Runners often complain of knee pain. The knee is inherently an unstable joint, and often injuries occur because of that instability. It is important to understand that we address knee pain by first relieving any compensatory stiffness above and below the joint, such as in the quad, hamstrings, calf, and TFL. Then, once the motion is restored, encouraging stability through strengthening and motor control. We will only have enough time to really address compensatory stiffness, but it can be helpful to discuss the importance of stability with your participant. The hip is also a common complaint for athletes. It often presents in the hip flexor, the psoas, or in the glute med. We will discuss techniques for assessment and treatment for the hip in this video as well. It can be helpful to have participants remove their shoes and have them stand barefoot for your assessment. You can assess for valgus or varus positioning of the knee in standing. You can also check the positioning of the tibial tuberosity to look for internal or external rotation of the tibia relative to the femur. A toe touch is helpful to analyze the posterior line fascia. The posterior line fascia tracks from the plantar fascia all the way up to the top of the head, and a dysfunctional toe touch can give you a hint whether any hamstring tightness is linked up the posterior chain, such as in the lumbar spine. So keep in mind that hamstring tightness may not be the fault of the hamstring alone. It might be a more proximal or distal connection that is causing the issue. You can also have the participant do a squat, checking for how much dorsiflexion you see at the ankle, and looking for any hip stiffness that may be contributing to knee pain. You can also look for valgus collapse during a squat, which may indicate hip weakness and contribute to the knee pain. This sort of dynamic testing can be an important hint as to whether there is a static or dynamic dysfunction or both. This means the problem might be absent while standing, but might reveal itself during movement, and these dynamic dysfunctions are very important for athletes, as they are exacerbated by significant movement such as a long run. You can also do a gait assessment, looking for valgus or varus collapse and Trendelenburg gait, which may indicate hip weakness. Again, the dynamic dysfunction might only reveal itself during movement. Next, you can have the participant lay on their back, so you can start with a passive assessment. In this position, you can do an active straight leg raise, where you have the participant keep their leg straight and actively lift their leg, bringing their hip into a flexed position as high as they can go. Then you can do a passive straight leg raise, where you will lift the participant's leg into the same position. If you move farther than they were able to do on their own, they have a motor control problem. This means they do not have the ability to control their motion. If you move to the same point they were able to do on their own, they have a stiffness problem. This second option is something we can surely address in our treatments. Next, you can do a knee flexion test, bringing both their hip and knee into full flexion and checking the quality of the motion. You will want to see if there's any pinching or pulling. Then you can do a Thomas test, checking for anterior thigh tension. If you notice that the knee shifts laterally during a Thomas test, you may have an IT band or TFL issue that you're working with. You can also do a hip assessment, where you can check internal and external rotation of the hip as well as flexion. You already tested extension with the Thomas test. Now we will begin discussing treatments. We are going to start with the anterior side and then work on the posterior side. The first technique is flossing into flexion and extension of the knee. You want to make sure you have a good hold on the leg while you're doing this so the participant really trusts you. Don't push the end range too much. The goal is to focus on getting it moving. The second technique is an effleurage technique, starting below the knee and pushing up with different pressure depending on pre or post event. You will want to use lotion, especially if there is some leg hair present. The goal is to have as much circumference of your hands on the knee as possible while you are doing this. Make sure you put extra focus on the quad tendon. Another technique you can use is pressing your forearm into the quad and the quad tendon. This may be a pretty stressful position for some, so try not to put too much pressure, but be sure you're having an effect on the tissue. Addressing the psoas can be difficult because of how deep it is. What you'll want to do is find it, so have the participant keep their leg relaxed and bring your hand medial to the ASIS, and have the participant lift their leg into flexion. You should feel the psoas pop into your hand if you are in the right place. Then you will just want to hold pressure on it. This may be uncomfortable for individuals as they may not have had this sensation before. An important note about the IT band is that the IT band is actually not usually the problem. Keep in mind the anatomy of the IT band. It starts with the TFL, the tensor fasciae lata, which connects to the IT band and attaches at the lateral patella. When it gets tight, it feels like a pulling sensation laterally at the patella, and participants may mention that to you. To impact the IT band, you will actually want to press on the TFL. The thick band of fascia we call the IT band isn't really well treated by inhibition, but the TFL is. It's like if you have a towel connected to a rubber band. If the rubber band is tight, the towel will be more taut too, but putting pressure on the towel doesn't fix the problem. You have to treat the rubber band. To treat the TFL, you will first want to identify its slightly posterior, inferior, and lateral to the ASIS, and then you'll use inhibition to treat. It will be uncomfortable for participants, so adjust the pressure as needed. You can use the same techniques of flossing and effleurage on the posterior thigh. For the effleurage on the posterior thigh, you can make a W with your thumbs and put pressure into your thumbs and hands while positioning your thumbs between the hamstring muscles. You can also do some cross-tissue work on the posterior thigh, as well as attack and stretch into internal and external rotation. The glute med is often a source of tension as well. You can make a fist and put some light pressure into the glute. If they are tolerating the force well, you can use an elbow and just press your body weight into the tissue. You can also move inferior to find the piriformis and put pressure on it there.